Assalamu alaikum. This lecture is on the use of lasers for transoral laser microsurgery of laryngeal carcinoma. Transoral laser microsurgery, TLM, is now a well-established treatment option for early laryngeal carcinoma for T1 and T2 laryngeal carcinoma, with results very comparable to radiotherapy and even open surgery of the larynx. This was confirmed by a Cochrane review and has now found its way to the national guidelines recommendations for early laryngeal cancer, which can now be managed by either of the three modalities. The TLM is oncologically safe and has good function preservation. It preserves voice and swallowing and quick recovery, and also it is repeatable. It can be repeated several times. There are space for improvements in the laser technology with the introduction of semi-flexible robotic systems and even better access to visualizing the larynx with better scopes and better techniques in the future. Because the lasers TLM provides an unobstructed view of the operations field. It also causes minimal tissue manipulation and better hemostasis, and is quicker, very short duration, and it is repeatable, and it is cost effective compared to, for example, radiotherapy. On the other hand, it requires adherence to safety protocols and proper training of the medical staff, and significant cost implication for the equipment and the upkeep of the equipment. And also it has a reputation for giving a poorer speech in the first year after treatment, particularly for the advanced laryngeal cancers T3 and T, and in the very few T4s that have been managed with lasers. The well-cited and followed classification of the European Laryngological Society of different cordectomies provided the anatomical, the functional, and the oncological basis for different types of surgical intervention, transoral microlaryngeal intervention for the treatment of cancer larynx. The first 8 were suggested in the 2000 meeting, followed by a 9th, the type 6 cordectomy in 2007. It starts with the type 1, the simplest, a subepithelial type of resection for dysplasias, carcinoma in situ, and very early T1A laryngeal cancer of the glottis, for example, followed by the type 2 subligamental, which would also resect the vocal ligament in deeper penetration or extension of the tumor, and a type 3 when the tumor reaches the muscle, the vocalis, the medial band of the thyroarytenoid muscle, and type 4, which involves the whole structure of the vocal fold. This is followed by 4 different additions in type 5, additions to the cordectomies in 5A. There will be an addition of the anterior commissure and part of the contralateral side if that's involved. In 5B, the addition will be removal of part or total of the arytenoid, and in type 5C, when the tumor extends to the ventricular fold, and type 5D when it extends to the subglottis, and then the type 6 is when the anterior commissure and the anterior parts of the vocal folds, either unilateral or bilateral, are involved. Starting with the milder form of intraepithelial laryngeal tumor, carcinoma in situ, or laryngeal dysplasia. This whitish patch, which can also be reddish, unilateral or bilateral, can be histologically very different. From the very benign end of the spectrum, it can be just hyperkeratosis, or it can be frankly malignant with microinvasion with squamous cell carcinoma cells. There are 2 ways of knowing how deep this lesion extends. One of them is following it by a stroboscopy and seeing its effect on the mucosal wave, and this is fairly sensitive and accurate. The other is a subepithelial injection of saline intraoperatively, and Following the injection, you could see whether the lesion will be lifted off together with the epithelium of the Arytenoidectomy space, or if it is tethered to the vocal ligament. If it is tethered, the saline would accumulate around the lesion rather than the whole epithelium with the lesion would be raised up. This would give the appearance of a donut, the donut effect. The UK consensus statement on the management of laryngeal dysplasia favors excision biopsy of the laryngeal dysplasia lesion by the use of carbon dioxide laser, although cold steel excision can give comparable results. The benefits of using carbon dioxide is a better control of the surgical field and less bleeding in addition to precise incisions. The use for laser to ablate the lesion rather than excise it is discouraged, as it would have collateral damage to the lamina propria and the voice, and will also destroy material that can be useful for histological examination and grading of the lesion. Vocal fold stripping is not recommended. If the lesion is primary, that is a new lesion with no previous history of recurrence, then the use of radiotherapy for the treatment should be offered only with discretion, only in very selected cases like poor access and visibility of the larynx, or when the resection has a high risk on a patient with poor health. Currently, the only indication for open partial resection and biopsy would be a very inadequate exposure of the lesion by endoscopic route. Carbon dioxide, TLM, is increasingly becoming the standard treatment for carcinomas in situ and T1 lesions, glottic tumors. The voice quality may be slightly better with radiotherapy, but several big series showed that the oncological outcome in terms of local tumor control and survival rates are very comparable for the two modalities. Carbon dioxide, TLM, has an advantage, the cost-utility advantage. The excised lesion would have to be marked before sending it over for frozen section, marking where is anterior, posterior, medial, and lateral. And if for any reason the resected margin is too close to the lesion, an extra 2 millimeters can be taken from the affected area, including the tumor or the lesion bed as well. The operation type for this very early carcinoma in situ or T1 lesions would be the subepithelial cordectomy type 1. In this type of intervention, the epithelium only, the squamous epithelium of the vocal fold would be resected together with part of the superficial layer of the lamina propria. This specimen would then be presented for histological examination. The vocal ligament itself, marked here in blue, would be spared. The dissection would just involve the surface epithelium and part of the superficial layer of the lamina propria. This can be helped very much by intraoperative injection of saline in the Larynx space, and this would lift off the lesion of the lamina propria and show whether it is attached to the vocal ligament or not. The use of this very simple technique had helped in raising the adequacy of this type of resection from 60% to 90% success rate. Some early success was also achieved not only by carbon dioxide lasers, but with other photoangiolytic types of lasers, including KTP, for example. They showed very promising results by selectively destroying the microvasculature of early glottic tumors. For the cordectomy type 1, the laser settings would be a spot size of 2 millimeters length and 2 millimeters penetration. This will be reduced down to 1 millimeter penetration in the lamina propria, and the power would be anything between 5 and 10 watts in the super pulse wave with a single pulse mode. Incision line here would cut into the epithelium, and then dissection would be carried out in the lamina propria. Sometimes you can use a micro spot rather than a 2 millimeters length. Here, a very tiny micro spot, then you can reduce the power settings. Again, you can use super pulse mode with an 0.1 to 0.05 seconds duration of the pulse. And once the dissection is completed in the deeper parts of the lamina propria, sparing the vocal ligament, this white structure here, the specimen will be sent for frozen section, and any extra bits of safety margins can be taken then. With stage 2 T2 glottic carcinoma, the results for radiotherapy and carbon dioxide TLM are equivalent. A meta-analysis had recently showed no significant differences in the 5 years local control rate or the preservation rate of the larynxes in the two modalities. But this is basically for T2A with normal vocal fold mobility. When the vocal fold mobility is affected or impaired in T2B, or when there is extensive anterior commissure involvement, then the efficacy is reduced. Although some experts would argue that you could still go on and treat this anterior commissure involvement without much reduction in the success rates. If the malignant tumor extends deep into the Larynx space or is affecting the vocal fold ligament and affecting the vocal fold mobility, then the operation of choice may be the subligamental cordectomy, provided the infiltration does not go beyond the ligament, does not go into the muscle core of the vocal fold. The type 2 cordectomy would be selected. This would entail resection of the epithelium, the Larynx space, and the vocal ligament formed of the elastic and the collagen fibers of the lamina propria. The dissection would be carried out between the vocal ligament and the vocalis muscle, sparing it from the tip of the vocal process of the arytenoid anteriorly to the anterior commissure. This was usually done when the stroboscopy shows loss of mucosal wave or the saline infusion shows the characteristic donut appearance. So this operation is ideal for microinvasion carcinoma or severe or recurrent carcinoma in situ. The outcome for T2 glottic carcinoma between the carbon dioxide laser TLM or radiotherapy are almost identical. For the 5 years local control rate, they are very similar, and also for the preservation rate of the larynx, they are very similar. Of note here that the best results are those of the open partial laryngectomy, but of course this comes at the expense of functional impairment and difficulties with the voice and the swallowing, and a possibility of a permanent tracheostomy and prolonged post-operative rehabilitation. When the tumor infiltrates a bit deeper to affect the vocalis muscle, the medial band of the thyroarytenoid muscle, but without affecting the mobility of the vocal fold, that is to say a T2A, then the operation of choice would be a type 3 resection. And the type 3 resection, the epithelium, the whole of the Larynx space, the vocal ligament, and the medial part of the thyroarytenoides, the vocalis muscle, will be resected. The line of separation between the resected area here would be between the vocalis muscle and the remaining part of the thyroarytenoid muscle. The procedure may be helped by trimming of the ventricular fold in order to improve visualization of the lesion. In type 3 cordectomy, the incision will be between the vocalis muscle medially and the remaining part of the thyroarytenoides laterally. The beam, the spot can be a micro spot or can be as long as 2 to 3 millimeters with a penetration of 2 millimeters in depth. Power can be anything between 5 and 10 watts, super pulse in a single pulse mode with a pulse duration of 0.1 seconds. You would maintain traction and counter traction so as to note the difference between normal tissues that would spring open when incised with the laser, or the tumor tissues that are tougher and would char and would resist springing. Once the deep margin of the tumor is identified, the host disease interface is followed with the laser, as in here, to excise the tumor, the vocalis, the superficial the lamina propria, and the epithelial cover. The dissection is now complete. If the tumor extends deeply into the substance of the vocal fold thyroarytenoid muscle, causing vocal fold impairment or immobility, like in T2B, here the operation of choice will be a type 4 total or complete cordectomy. The whole of the vocal fold contents would be resected from the vocal process of the arytenoid to the anterior commissure, and from the free medial edge to the perichondrium of the thyroid, or even sometimes including the perichondrium of the thyroid, together with trimming of the edges of the ventricular fold to improve visualization during the operation. The total or the complete cordectomy would start with a posterior transverse cut in front of the vocal process of the arytenoid, all the way laterally towards the thyroid ala, the inner perichondrium of it. And the specimen would include the whole of the thyroarytenoides, the lamina propria, and the epithelial cover. Then the resection with the laser. Here we're using a 3 millimeters length with higher power, up to 10 watts. Here the Broyles ligament is detached, the anterior commissure area is detached, and the resection would continue circumferentially through the muscle remnants in here to remove the whole content of the vocal fold, leaving around only the inner perichondrium of the thyroid ala. Here we are detaching the tumor anteriorly from the Broyles ligament area of the anterior commissure, and now the whole of the tumor has been removed. The next 4 types of cordectomies involve extension of the tumor into specific areas. Starting with type 5A, the tumor has extended close to the anterior commissure or even the anterior part of the contralateral side. So a type 4 cordectomy would be carried out with an extension anteriorly to remove the tumor from the anterior commissure and the anterior part of the contralateral vocal fold. The plane of dissection here would be at the base of the epiglottis and passing through the Broyles ligament. The lateral edge would be the inner perichondrium of the thyroid ala, and the medial part would be the free margin of the vocal fold, and posteriorly it would be the vocal process. And the whole of this area would now be resection. There are some arguments here about the success rate of this type of procedure and the difficulty in accomplishing a clear margin around the anterior commissure area, but the advocates of this type would insist that it's still oncologically sound. The next extended cordectomy is when the tumor reaches posteriorly the arytenoid area here. The operation of choice would be the type 5B cordectomy with Arytenoidectomy as well. A total or a complete cordectomy like a type 4 with extension posteriorly to include part or even the whole of the arytenoid. There are again some argument here. Some authorities would maintain that if the tumor reaches the posterior towards the arytenoid, then an peroral approach may not be appropriate. But again, there is a counter argument about the efficacy of this operation, and success rates are not too different from success rates of comparable options. The third extended cordectomy operation would be the type 5C, when the tumor extends into the laryngeal ventricle, the ventricle of Morgagni. Here the resection would include a total or a complete cordectomy like a type 4, together with the ventricular fold and the ventricle of Morgagni, all in this area would be resected. The fourth and final extended cordectomy is when the tumor extends into the subglottic area. Here the operation would be a 5D, and still appropriate in some T2 tumors when the tumor extends caudally about 1 centimeter from the apex of the ventricle. It can still be carried out. Resection includes a total cordectomy like a type 4, trimming of the ventricle to improve visualization, and extension of the resection into the subglottic area to remove part of the tumor, provided that there is no cricoid cartilage invasion. And the ninth type of cordectomy, when the anterior commissure, together with either a unilateral or bilateral anterior vocal fold involvement, the type 6. Here the resection would include the anterior part of the vocal folds, either unilaterally or bilaterally, the Broyles ligament, part of the epiglottis, like you can see it in here, and the part of the epiglottis would also include resection of the angle of the thyroid cartilage and extension caudally into the subglottic space, particularly to involve the cricothyroid membrane, which can sometimes be necessary. This is type of resection required if the tumor is very anterior and you can spare the posterior parts of the vocal folds and the ventricular folds, so the resection would be anterior part of the larynx, including anterior commissure, the anterior parts of 1 or 2 vocal folds, part of the epiglottis on the base, and the thyroid angle, and a small part, if required, of the subglottic space, including the cricothyroid membrane. In supraglottic carcinomas, the carbon dioxide TLM is indicated for the early stages of the supraglottic tumors, the T1 and T2, where it provides comparable results to radiotherapy and open surgery. And particularly for small lesions, it is best to have the carbon dioxide laser modality because it maintains better the swallowing and the voice. When it comes to T3, most of the T3 tumors, supraglottic tumors, are treated non-surgically, usually by chemoradiotherapy initially. But very small T3 lesions can occasionally be resected by the type 5C cordectomy, total cordectomy with extension into the ventricular fold. Subglottic cancers. The subglottic area is not very accessible for transoral microsurgery because of visibility and limited exposure. However, you can use the carbon dioxide MLD in some cases. Most early subglottic tumors, the T1 and the T2, are treated with radiotherapy, but surgery in the form of laser can be reserved for the subglottic extension of glottic primaries rather than a subglottic primary. If the glottic primary does not extend further than 1 centimeter and does not involve the cricoid cartilage, or when there is a recurrence or a failure of radiotherapy in the treatment of a primary subglottic tumor. The use of lasers, transoral lasers, in the management of advanced stages of laryngeal carcinoma like a T3 and T4 remains a matter of debate. Some T3 tumors, selected T3 tumors, particularly the supraglottic ones, may be managed by transoral lasers with some not too bad results. A recent meta-analysis of T3 laryngeal cancers showed that the 5-year overall survival was about 2 in 3 for patients treated with transoral lasers. This may suggest that the transoral lasers microsurgery may be seen as an organ-preserving option in selected cases of T3 tumors. For T4 tumors, the TLM is rarely used when there is, for example, cartilage invasion or extralaryngeal spread due to the poor access and also a fairly high recurrence rate. The usual management is open laryngeal surgery in the form of laryngectomy. We now move to comparisons of the outcome of carbon dioxide lasers versus different other modalities in early stages of laryngeal carcinoma, starting with carbon dioxide laser versus radiotherapy in T1 and T2 laryngeal carcinoma. A meta-analysis of 22 different studies showed no significant differences in the local control rates or the laryngectomy-free survival between the two modalities. Some studies had noted slightly better voice for the radiotherapy patients. On the other hand, carbon dioxide lasers offer shorter treatment period. It's just one procedure versus weeks of radiotherapy treatment, less toxicity, and lower cost. Another systematic review, specifically of T2 glottic carcinoma, showed a 5 years local control rate essentially identical between the two modalities, but there was a trend towards a higher larynx preservation with the laser patients. When the comparison is extended to advanced stages, T3 and T4 laryngeal carcinoma between the laser and chemoirradiation, remember that primary chemoradiation is the standard method of treatment for advanced laryngeal carcinomas, the T3 and the T4. Carbon dioxide TLM is not combined with chemo, generally is not with chemotherapy. Rather, it is used as a salvage after failed chemoradiation failure or as an alternative to chemoradiation therapy in select T3 cases, some T3 cases, and is rarely used for T4. The meta-analysis of 5 years survival showed that carbon dioxide laser could offer about a 2 in 3 survival for T3 glottic carcinoma 5 years. But of course, the chemoradiotherapy results, the historical results, showed this figure to be higher at 77% or so. That's why it is the standard method of management for T3 and T4 laryngeal carcinoma. Now, comparing carbon dioxide laser versus open surgery for early glottic tumors, the results of carbon dioxide are generally similar cure rates to open partial laryngectomy, but with lower morbidity. In T2 glottic cancers, the pooled analysis showed a better results for the open surgery for the hemilaryngectomy. The 5 years control rate was 94-point-something% compared with just 75% success rate for the carbon dioxide laser. But importantly, the open surgery and the carbon dioxide both yielded excellent organ preservation. It was still higher in the open surgery. 95% had retained of the patients returned their larynxes, compared with only 86.9% for the laser, but both figures were better than the radiotherapy group, which only 82% of the patients retained their larynxes. Open surgery has higher success rates from T2 onwards, but it's more morbid, of course. The carbon dioxide lasers offer better functional outcomes and quicker recovery, and therefore the open surgery is reserved for tumors not amenable to complete endoscopic visualization or requiring extensive subglottic or cartilage involvement. So generally, the carbon dioxide TLM for the stage 1 T1 glottic carcinoma, it provides excellent 5 years disease-free and larynx preservation, above 90% and amounting to 100%. the overall survival is very high, more than 90%. So for the early stages, particularly the T1 glottic, carbon dioxide laser may be the preferred modality of treatment. A meta-analysis found no significant differences between the carbon dioxide and the laser and the radiotherapy in the local control of these very early tumors. There was a suggestion that the voice outcomes are generally better in radiotherapy, but we'll come to this later. Complication rates for the carbon dioxide lasers are very low, in the form of transient aspiration or some granuloma tissue in few patients. The outcomes for stage 2, the T2 glottic carcinoma, are lower, obviously, than those for the T1. The 5-year survival remains high at 85 to 90% compared to more than 90% for the T1s. But the local control rate is about 3 and 4, 5 years local control rate for the laser. This is very comparable to the radiotherapy. And the larynx preservation rate for 5 years was still high at 87%. The complications at this stage, the T2s, include permanent tracheostomy or severe stenosis, laryngeal stenosis from the scarring and granulations and webbing, but these are uncommon. Minor complications in the form of a temporary tracheostomy accounted for 7% of the patients, or webbing or granulations, particularly at the anterior commissure, for 5% of the patients. The carbon dioxide TLM outcomes for stage 3 in the selected cases of T3, not all T3s were treated with the carbon dioxide TLM. In the selected cases, the results were not too bad. The overall survival was somewhere around 2 in 3 patients, 5 years. 63 for the glottic T3 and higher, 68% for the T3 supraglottic cancer. So it's about 2 in 3 5-year survival by carbon dioxide TLM. The larynx preservation is not too bad at 77% for glottic and a bit higher for the supraglottic cases. And the disease-specific survival was at about 80% for both sides, the glottic and the supraglottic. So although the outcomes for carbon dioxide lasers in the selected cases of T3 is still in line with organ preservation, chemoradiotherapy, for example, the risk of local recurrences is higher. And for most patients with T3 laryngeal carcinoma, adjuvant therapy would be required or eventual laryngectomy. The functional results in the selected cases are very good in terms of voice and swallowing, but tend to be modestly impaired compared to the outcome for voice and swallowing in the T1 and the T2. That's natural, of course. Therefore, the carbon dioxide TLM is not routinely used in T3. It's typically offered only when a tumor can be fully visualized and can be completely resected endoscopically in some selected cases. For the advanced stage T4 laryngeal carcinoma, the carbon dioxide laser microsurgery is generally not indicated. The standard line of treatment, first line treatment, is a total laryngectomy and adjuvant radiochemotherapy. These are advanced tumors. Very few cases, like in the rare event of a downstaging of a T4 or very limited T4A lesions, laser resection has been attempted, but there are no standard outcomes from these very few reports. And now to the complications of carbon dioxide transoral laser laryngomicrosurgery. In experienced hands, carbon dioxide laser is safe. It can cause minor or temporary problems in the form of some edema of the laryngeal inlet and anterior webbing around the anterior commissure and some dysphagia, but these are infrequent. In one series of 43 glottic cases treated with carbon dioxide laser, only about 7% required a temporary tracheostomy, and between 4 and 5% had an anterior web or stenosis requiring revision surgery. Serious events like, for example, airway fire are exceedingly rare with the proper precautions in place. Overall, the carbon dioxide laser avoids prolonged dysphagia and systemic toxicity associated with, for example, radiotherapy or chemoradiation, but at the expense of slightly higher risk of focal scarring, particularly around the anterior commissure. The postoperative management and the very important issue of a follow-up. A strict voice rest is generally advised for the first 2 days, and after that the voice and swallowing rehabilitation may start. The carbon dioxide laser patients would require a very close follow-up. So important this is to the extent that the operation should not be recommended to patients who may not be able to commit to a regular close follow-up, particularly in high-risk cases like T2 tumors involving the anterior commissure or more advanced lesions like a T3, for example, because radiological investigations in the form of repeated scans or adjuvant treatment may be required in the post-operative period, so the follow-up here is essential. And finally, to the issue of post-operative voice. There is a common argument that the voice of patients who had laser surgery is inferior to those who had radiotherapy and the treatment of glottic tumors. This has been a common theme. A closer look at these pooled results of several groups of patients treated by laser therapy in the first 2 columns, or open surgery in the form of partial open laryngectomy in the last 2, or by laser in the middle 3, early and moderate and advanced lesions. You could see the comparison between the preoperative maximum phonation time, which may reflect the glottic competency. In blue, again, is the postoperative maximum phonation time in red. And you can see an obvious improvement in the radiotherapy groups, particularly those who had the newer techniques with the better machines. That's not the case with hemilaryngectomies. You could see that the voice had deteriorated markedly after the operations in the open surgery, open vertical hemilaryngectomies. In the laser groups, you could see a slight improvement in the voice in the early stages of laryngeal carcinoma. Actually, the voice improved after therapy, in line with the improvement noticed with the radiotherapy. But it is those patients who had advanced tumors treated by laser that would have a deterioration in their post-operative voice in these 2 other groups. For the type 1 and type 2 cordectomies, laser cordectomies, they don't have significant difference in their voice outcome compared with the normal subjects or patients who had radiotherapy for laryngeal tumors. Those who have had more extensive resections or procedures do have a greater dysphonia, like we have noticed in these 2 groups. In these 2 groups, only 10 to 20% required further surgery. After a year of a disease-free interval, they required a medialization procedure in order to improve the maximum phonation time, to improve the glottic competency. This is usually done as a medialization, type 1 thyroplasty, and preferably with Gore-Tex rather than a rigid type of a prosthesis, because the new cord is fragile and may split with the use of a tougher prosthesis. The other cause for dysphonia is anterior webbing at the anterior commissure or adhesions, and these would need synechia divided, usually by laser surgery, and sometimes laryngeal anterior commissure stent placed together with application of mitomycin. This would apply to between 10 to 20% of patients treated for advanced laryngeal cancer by major resections. By this, we come to the end of this lecture on the use of carbon dioxide laser, transoral laryngeal microsurgery, and the treatment of laryngeal carcinoma. Assalamu alaikum.